So again, we have received some questions from the audience regarding the topic of data collection. How do you manage parental consent in neonatal data collection? I think this is a very fair point.
Thank you very much. That is a very, very good point indeed. When you have 100,000 babies admitted to neonatal units and neonatal staff are very, very hard pressed, it's been accepted by our Health Research Authority, which is the regulatory authority in the UK, that you can't ask for individual opt-in consents. But what we do is provide information in multiple different ways. So all neonatal units are, the recommendation is that they include, we have an information sheet about the National Neonatal Research Database. That's available on our website. Any of you can have a look at it and see what it says. Any parent can go there and see what it says. Neonatal units are asked to provide a copy of that information sheet to all parents who are admitted to a neonatal unit, and parents are free to opt out of their baby's data being included. So if a parent wishes not to have their baby's data included in the National Neonatal Research Database, they're absolutely free to opt out. And we have, in England, we have something called a standard NHS opt-out mechanism, because this opt-out of the use of patient data applies to other specialties, not only neonatal medicine. And so we have multiple ways in which parents can opt out. They can opt out by telling their clinical team in the neonatal unit, and the clinical team can inform the relevant authorities to not include the data. Or they can use the NHS opt-out, in which case the same thing will happen, the baby's data won't be included. But we're asked to provide opt-out rates every year to our regulatory authorities, and the opt-out rate is extremely low. It's been less than 1%. So parents are on side with this. They want us, and we've done a lot of focus group work too, and they say to us again and again and again, please use our data, and why are you asking us this question? We thought we were using it for benefit anyway.
Thank you very much for this great answer, and it's really good to see that parents really support the data collection for research purposes. So the next question is about putting evidence into practice, or we talked a lot about putting evidence into practice and how we should do that. And this question is directed to the biggest evidence gap. So where do you believe is the biggest evidence gap today in own mother's milk or infant feeding?
Oh my goodness! As I say, we could. I mean, there are so many evidence gaps. There are so many evidence gaps. I mean, the one thing that we should hang on to, though, is that we want our babies to be receiving their own mother's milk, and we want them to be breastfeeding. We want them to go home from our neonatal units breastfeeding, and we want that breastfeeding to be sustained. So I think we should hang on to that first and foremost. There are all sorts of other issues that are huge uncertainties, really, really, really important uncertainties in newborn care. I mentioned in my talk the fact that, for example, in some countries, macronutrient fortification, and I'm not talking about micronutrient or vitamin supplementation, but macronutrient fortification is standard of care. It's not standard of care in all countries. And if you look at the evidence is uncertain. There are legion examples of where the evidence is uncertain in nutritional practice. So I think we must be, and this is why I emphasize the fact that we should be honest with our families. It was one of the important things that came out of the focus group work that we've done, not only with parents in Europe, but parents in the UK as well. And that is that where there is an uncertainty, we should tell parents there's an uncertainty, because they would be first and foremost with us in wanting to help take part in research to resolve those uncertainties.
Yeah. Then there are several questions regarding potential metrics that one could measure. And Miguel is challenging you a bit. Any own mother's milk at discharge is not a very good marker of future success. Can we search for other measurements? For example, milliliter per kilogram per day of own mother's milk, or the percentages of own mother's milk?
I don't disagree with you, Miguel, but I think that at least when we're starting, we should start simply. Because if we want to capture these sorts of, or develop these sorts of metrics across all neonatal units for all babies, then we need to keep it simple to start with, because otherwise it'll be too burdensome for clinical teams, and they're already working extremely hard. So I would say let's start with something that's small and simple and easy to do. I'm not being precious about what that metric is. I think there are many things that we could choose, and it's something that hopefully you'll be in a position to discuss at the workshops tomorrow, because it'd be very interesting to get the views of the assembled company about what are reasonable, straightforward, simple metrics that we can all agree on. And let's start with those simple metrics, and then as we get good at that, we can get more and more complicated.
Yeah. And you have even stressed a barrier. It needs to be easy, that the staff really has the resources to do it. And the next question asks, who collects the data at the hospital? Medical staff of the hospital or additional persons? How is it in the UK?
So as I say, we like many countries, have moved increasingly to use electronic medical records. Who enters the data into the medical records is very variable across neonatal units. And very often, certainly in my own neonatal unit, it's just a shared approach. So the nursing staff will enter some data, the medical staff will enter other bits of data, and we just very recently, just last year, have got a single administrative support staff who will enter some data. So it's very, very variable. It is a team approach. And I do think that a team approach is really important, because it makes the point that, as somebody said very powerfully earlier today, this is an issue for all of us. And to simply say, well, it's your job and it's not my job, is not particularly helpful. So splitting up the workload in this way, I think, is not a bad idea. But we've asked our e-newborn colleagues, all of those who contribute to e-newborn so far, what are the barriers and obstacles for them when it comes to capturing data? And one of the points that they make again and again and again is the difficulty of finding time and staff to actually capture data. And again, I think this is an area for where possibly collective advocacy would be very powerful, because if we are going to use data to maximum effect, then that data really needs to be high quality data. And you just can't leave that to chance. You have to make sure that neonatal units are adequately supported to record the data, and that there is adequate resource to make sure that the data are complete and that they are reliable and accurate. So it can't be, we can't say, oh, well, that would just happen quietly in the night. No, it has to be done properly.
The next question also refers to the research database. I'm not sure if it's the UK one or the European. Will the research database be able to look at outcomes for different population groups, also the socioeconomic, ethnic, and geographic different groups, to explore barriers for these different groups and people?
Well, let me give a qualified response to that. Observational data are not randomized controlled data. And so observational data are very good at understanding what's going on, but they are less good at actually being able to test hypotheses and draw really strong conclusions, because of course you're always left with the problem of confounding. If you compare a group that gets X with a group that gets Y using observational data, you cannot necessarily reliably say the difference between the two groups was due to the difference in the intervention, because of course the difference may be the result of confounding through other variables. And it is a huge danger to rely on observational data to answer really important questions. It's also a hugely, potentially damaging issue for our babies to conflate an association with a causal relationship. The best example I can give of that is, there's a very strong association of the number of people who go out every day carrying an umbrella and whether it's going to rain. But the fact that you go out carrying an umbrella doesn't mean it's going to rain. So there's the difference between an association and causation. And it's a classic mistake that happens again and again and again in the literature and in discussion. Just because there's an association, it does not mean there's a causation. So I think databases, there are very sophisticated statistical techniques that can help you elicit causality from observational data, but for that you need large amounts of data. And I would say it's very dangerous to try and do that on a small data set. So the more we collaborate, the more data we accumulate, the more likely we are to be able to use these observational data effectively.
So this is also a call to action to the audience,
Yes.
right? To join the network, to feed in the
Yes.
data. I hope you all heard it. So for those of us leaving here today and who are ready to measure, what would you recommend as the key metric or top 3 metrics that we should prioritize out of the table you have shown before?
Oh, I'm going to dodge that question. I'm not going to answer it at all because I think that is a job for all of you who will be attending the workshops tomorrow. So forgive me, I'm going to duck out of that one.
We will let you know about the outcomes. So thank you. I think we had a fantastic discussion. With that, I would like to close this panel discussion.
Thank you very much.
Thank you very much, Nina.
Thank you.